Good afternoon to everyone. So we are going to start this session, and I would like to thank GE Healthcare for this symposium, and also I would like to thank all of you participating, and all my speakers, which I'm really grateful that they're here, and I'm also emotional about that because they are one of the leaders in the arguments that they are going to talk about. And for those of you that don't know who I am Dr. Castellano. Just a little bit of my background. I come from University of Federico II, the Department of Servillo, and also, which I like to thank, and right now I'm the chief at the university at the Gemelli Molise Hospital. Now, this argument in this session is really interesting today because we all know that there's a lot of talk about big data, there's a lot of talk about artificial intelligence, machine learning that we're going to talk about. To all of us, it's a common goal, basically to give the best possible care at our patients. And today, technology will give us great help on all this that we are going to talk about today. So I would like right away, he doesn't need any presentation, Dr. Frederic Michard, that he will talk about protecting patients, the case for wireless wearables on the wards. Michard, thank you.
Thank you very much for the invitation. Thank you. So thanks for the invitation to talk about wireless wearable on the wards and how or why we should monitor ward patients differently. So first, I'd like to briefly disclose the fact I'm today leading a consulting and a research company, MICO, based in Switzerland, and where we focus on digital innovations with medical applications. So, as you know better than me, many patients go to the hospital for surgery and have to stay for complications. We know from the large international outcome study that around 17% of patients undergoing surgery develop at least one postoperative complication. It's actually more, 27% after a major surgery. So clearly, many high-risk surgical patients develop postoperative complications, and these complications may be detected with a delay, mainly because of the intermittent nature of spot check done by nurses, classically every 4 to 6 or 8 hours. So now we are able to monitor continuously vital signs. We can quantify how much we are missing when we just do a spot check from time to time. So this is a very interesting study from the Cleveland Clinic. And they showed that where nurses were spot checking SpO2 every 4 hours, they were actually missing 82% of hypoxemic events. And when they were measuring blood pressure every 4 hours, they were missing 79% of hypotensive events. So we all know opioids may induce respiratory depression, and there is today a consensus to say that no patient should be harmed by opioid-induced respiratory depression. I will here simply quote Dan Sessler in this editorial published in Anesthesiology a few years ago. It is likely that many catastrophic respiratory events could be prevented if we were monitoring continuously respiratory variables. We all know the nurse-to-patient ratio is often suboptimal, not to say far too low on regular wards. And you may have seen, like me, these kind of studies showing that in only 40% of the ward patients, vital parameters are actually monitored as was instructed. I find this systematic review very interesting as well because it demonstrates an inverse relationship between failure to rescue, that is to say deaths related to postoperative complication, and the nurse staffing level. So here we have two options. We can either dramatically increase the number of nurses working on the wards, and we know it's unlikely to happen, or we can try to upgrade the way we monitor, to improve the way we monitor patients on the wards. In-hospital cardiac arrest often occur on regular wards. This is a very interesting audit done by the team of Jerry Nolan in the UK. A very large number of in-hospital cardiac arrest, and as you can see, more than half were actually occurring on regular wards where, once again, we check vital signs only from time to time. And so what does it mean? It means in practice, we know many patients don't suddenly deteriorate, but we suddenly notice just because of this intermittent spot check. As you know, there is clearly a trend towards the admission of older patients with multiple comorbidities, and these patients are obviously at higher risk to develop complications. Overwhelmed ICUs cannot always cope with the surge of acutely ill patients. It became obvious during the COVID-19 pandemic. And that's why with Bernd Sögel from Germany and with Benoît Vallée from France, we propose not only to increase the number of ICU beds in the future, but also, and maybe more importantly, to upgrade the way we monitor patients on regular wards. And it's going to be possible because the good news is that remote and wireless monitoring solutions are now available. So which variables should we monitor more closely? There are different ways to answer this question. The first way is simply to look at triggers of rapid response team activation, and you see that actually all vital signs are triggering rapid response team interventions. We can also have a medical approach, I would say, or a physiological approach, and look at the most common complications after surgery and the deviations of vital signs. And you can easily imagine that heart rate is going to be a very sensitive variable because often abnormal in almost all complication states, but it's not going to be specific. And we can also look at the respective value of respiratory rate and oxygen saturation to realize that monitoring respiratory rate is probably more informative than monitoring SpO2 alone. Another way to answer this question is to look at machine learning algorithms that are integrating vital signs in their computation. And this is a very interesting study. You see a huge number of patients, and they were trying to predict with a machine learning algorithm severe adverse events, which were defined either as a cardiac arrest, ICU transfer, or death. And then they ranked vital signs according to their predictive value, their ability to predict one of these severe adverse events. And you can see that once again, actually, respiratory rate was ranked number 1. So what are the existing remote and wireless solutions today? To monitor pulse rate, you can get that from any pulse oximeter, you know that. To monitor heart rate or even one lead ECG, you can do that with 2 skin electrodes. And very often, actually, today, electrodes are part of the same adhesive patch. SpO2, you are aware that today it's easy to find miniaturized pulse oximeters, and they have been increasingly used during the COVID-19 pandemic, actually mainly for self-monitoring from home, but we know we can also use them for early detection of clinical deterioration on hospital wards, pending, of course, these wearables communicate with nursing staff and send the information automatically either to a central station or directly to the smartphone of the nurse. Respiratory rate, as I probably already mentioned, is unfortunately today the neglected vital sign. We know that most of the time nurses, not most of the time, but too often I would say nurses simply guesstimate a respiratory rate. And it's a pity, because I already mentioned that it's a very important vital sign. And I think that's why over the last 5-10 years, many different methods, techniques, have been proposed to monitor automatically and continuously respiratory rate. So I have no time to describe all these methods. I'm just going to share with you a couple of examples to illustrate the fact that all solutions have not been created equal. Here you have an adhesive patch measuring respiratory rate from ECG variability and accelerometers. This is a validation study comparing to a reference method, and you see that only 77% of the measurements were actually part of the zones A and B, which are the safe zones of the Clarke grid. Here you have another one with 3 electrodes. It's based on impedance pneumography, and you see the same kind of validation study, but that time you have more than 99% of the measurements which are part of the zones A and B. So why that? It's probably because when you have actually 3 electrodes, you record larger changes in thoracic impedance as compared to what you would get from a small adhesive patch. Also, you have 2 channels, 2 signals. And so if for any reason you don't get the information you are looking for example, from the thoracic channel, very likely you will get the respiratory information from the abdominal channel. Here you see an example. Blood pressure. Actually, we can already today monitor blood pressure continuously as well. There are 3 main methods which have been proposed. The first one is based on the pulse wave transit time or the pulse arrival time. So to do so, you need an ECG recording and pulse oximetry recording. The pulse decomposition method, so you need a specific finger sensor, and this is a proprietary algorithm based mainly on reflection waves. And I think more interesting, we have machine learning algorithm using simply the pulse oximetry waveform. So the idea is to feed an algorithm or a computer with a huge number of pulse oximetry waveforms and corresponding blood pressure values, And so the algorithm or the system will learn how to recognize specific patterns associated with changes in blood pressure, either a decrease or a rise in blood pressure. Such a system has been developed by the ISICEM in Switzerland and tested by Patrick Schottker from the University Hospital of Lausanne in this study published in ANA a few years ago. And they were actually able to track accurately changes in systolic pressure on the left-hand side or changes in mean arterial pressure on the right-hand side just using the pulse oximetry waveform. So, okay, everything is nice so far, but is it really useful to improve patient safety? So this is a review article we published with Kurt Kalkman a couple of years ago. At that time, already 5 large studies had reported clinical outcome benefit with continuous monitoring on the wards. You see these are pretty large studies. These are before-after studies or implementation studies, not randomized controlled trials. And they all reported some kind of clinical benefits ranging from a decrease in rescue events to a decrease in ICU transfer or a decrease in hospital length of stay. There is even a study, the study from Sube from the UK, reporting a decrease in hospital mortality. Since this publication, a few more studies have been published. I share with you just an example of a recent one published in the British Journal of Anesthesia, where once again, when using continuous wireless vital sign monitoring, they were able to decrease the number of ICU admissions and the number of rapid response team calls. So far I shared with you the fairy tale. There are obviously a few challenges to the implementation of these new monitoring solutions. We did a survey last year to better understand what could be these challenges. We got feedback from over 1,000 anesthesiologists from Western Europe and from the US. And to the question, what are the main implementation challenges? First one for them, for clinicians, were economic. They say it's going to be too expensive. So it's important to realize that if these new monitoring solutions, of course, will mean an investment for the hospital, it's also important to bear in mind that the idea is to decrease the number of ICU admissions, to decrease hospital length of stay. So at the end of the day, it could be also economic value. And this is just an example with a study coming from the US, published in Critical Care Medicine. They implemented a continuous monitoring system on the wards. They actually observed savings ranging between 200 and 700 patients, $700 per patient, with an hospital break-even after 6 to 9 months. So clearly, potentially economic value as well. Second challenge, connectivity. I mean, we all experience disruption with Bluetooth connectivity. This is a study done with a sensor using Bluetooth connectivity. And you see that if in some patients it was working very well, so these patients were monitored over a 7-day period. When it's green, it means they got the signal all the time. And when it's red, it means they did not were able to record the system. You see that for some patients, it's clearly very challenging to get continuously vital sign information. So I'm not sure it's a big deal if we have in-home monitoring, because patients who stay home are not very sick, so I'm not even sure we need continuous monitoring. We probably need spot check from time to time. But in the hospital, clearly we need medical-grade connectivity protocols to ensure we get the information 100% of the time. Another challenge, maybe the nurse pushback. When you start discussing continuous monitoring with nurses working on the wards, not in the ICU, they say, oh, it's going to beep all the time, it's going to be impossible to deal with. So we need also smart algorithm to filter artifacts and prevent false alarms. We also need, as clinicians, to understand it's going to be necessary to personalize alarm thresholds and accept to increase the annunciation delay, meaning that it may alarm just after 3 or 4 minutes. That would not acceptable in the OR or in the ICU, but on the wards, keep in mind today, we monitor these vitals every 4 hours. So if you get the information only every 5 minutes, I think it's already a major improvement. So the impact on nurse workload is also very often a discussion. Of course, when they will start implementing any new system, just because of the learning phase, it may transiently increase nurse workload, but clearly the idea at the end of the day is to significantly decrease nurse workload so that they don't waste time measuring vital signs. It's done continuously, but also automatically, and then they can focus on different tasks. Last but not least, I like very much this feedback to the question where alarms should be heard and seen. Very few anesthesiologists, 12% said it should be heard in the room. And I think we should bear in mind, keep in mind that alarms have been designed for clinicians, not to disturb patients, not to increase their level of stress. And so it's also very important to have monitoring systems able to keep silent in the room, but simply inform the nurse at the central station or on their smartphone. So in conclusion, I hope, like me, you believe that it's time to rethink the way we monitor patients on regular wards. Because clinical deterioration may be overlooked for hours, we have now evidence. Solutions now exist for the automatic, continuous, and mobile monitoring of vital signs. They may help to improve patient safety and satisfaction, but also to decrease ICU admission and related costs. So I share with you my wish list. I think if you are interested in implementing such a system in your hospital or department, you probably need a mobile solution because we all know that early mobilization is a key element of enhanced recovery programs. It has to be comfortable to wear, otherwise patients will never accept it. It has been easy to use, otherwise nurses will not accept it. You need medical-grade connectivity protocol, otherwise you will have disruptions all the time if you use classical Bluetooth connectivity protocols. You need to be able to customize alarm settings and annunciation delays. You need a silent mode in the patient room. And of course, the data has to be transferred automatically to the electronic medical record systems so that they can calculate automatically early warning score or even more sophisticated score if they are available in your system. With that, I thank you very much for your attention.
Thank you very much, Michard. All the questions we will do at the end of the three speakers that will talk. Thank you very much, very interesting. The next speaker, his name is Felipe Gonzalez from Portugal. He's focused basically on many hemodynamics monitoring and advanced echocardiography. And he will talk about, could AI be the new teammate for ER or ICU shifts? It's, today, there's a lot of talk about this all over, so thank you, Felipe.
Thank you, G, for the kind invitation. I challenge you to answer this question, that is, could artificial intelligence be the new teammate for ER and ICU shifts? So we're going through all these topics to try to answer this question. And we start with this, because we already see the sound. Before this, we just couldn't hear the sound by the early Linux stethoscope, and now we just can see the sound, specifically the ultrasound, by these new ultra-portable machines that we can easily carry in our pockets as the stethoscope. So, and who's the new kid on the block, this artificial intelligence thing? So this is a big world with a lot of concepts and terms, and each of these terms depends on the other ones, such as deep learning is a subtype of machine learning, and machine learning is a subtype of artificial intelligence. And very briefly, very briefly, we have different types of algorithm learning, such as the supervised learning, unsupervised learning, and the mix of both, the reinforcement learning. And the supervised learning, we just have pairs of inputs and outputs that we give to the system and train to a predicted model. The unsupervised learning, we have a lot of scattered data, heterogeneous and then labeled data that he tries to recognize some patterns to give some insights about the clusterings. And the reinforcement learning, it's a mix of both. Of course, in echocardiography, we have these with the images. We just perfection the images and then train the model, and we get the prediction outcomes. And until now, we have several tools, such as auto-calculation tools, diagnostic tools, such as amyloidosis and sarcoidosis by the detection of the tissue, of myocardial tissue. And we have prediction of prognosis in heart failure and prognosis prediction. And there's a long way since 1985, and right now we have multi-chamber automated left ventricular analysis, and we have automated aortic root measurements. So it's very easy right now with these artificial intelligence tools. So which are our temptations? We now have a lot of auto tools that help us in monitoring the patient and to access the patient, like real-time ejection fraction, auto VTI, auto inferior vena cava, and detection automatically of B-lines. But we also have some pitfalls, In each phase we have some pitfalls, and we've been discussing here in the symposium that in each phase we have problems in validating these automated tools, in translating these into clinical practice, and into implement these in clinical trials or clinical decisions algorithms. So what are our team up to? So we started with some speckle tracking echocardiography in COVID patients that we collaborate with Frederic. And speckle tracking echocardiography is a quantification of longitudinal myocardial shortening during systole that is expressed as a negative percentage, that is the shortening, and usually ranges between less 20 and less 30%. As we have less negative values, that indicates a decrease in shortening, so a decrease in contractility. And we could access our patients, COVID patients, and detect earlier systolic dysfunction, either in right ventricular and left ventricular. So we then pass to the auto VTI. VTI is a very simple and easy measure that we can use in our algorithms to treat patients with shock or hypotension, and we can easily divide them on normal or high VTI or low VTI and manage patients with vasopressors, guides fluid management, and titrate other therapeutics such as vasopressors or inotropes. So our tools were these. We had several tools to compare, and we started with the GE venue family, and we used this auto-VTI machine learning algorithm. That is a neural network algorithm that is trained with thousands of cardiac images and automatically detects the apical 5-chamber view and the left ventricular outflow tract, and then automatically records hundreds of Doppler signals and extracts the most representative ones. Then it also gives the user the feedback regarding the image and the signal quality using a color coding that I'm going to show you. You see here, he recognizes the left ventricular outflow tract with a green color, which is good. Then we pass to the Doppler signals recording, and then he automatically gives us a mean of a 5-second period of them. And we can see here in real time how he recognizes the left ventricular outflow tract with a green code. We have the Doppler signals recorded, and if you put the left ventricular outflow tract diameter, you have a continuous real-time cardiac output monitoring. So we compared these auto-VTI measurements between experts and trainees, and actually the trainees behave very, very good. And then we went to the real-time left ventricular ejection fraction. So we did the same thing. It's also a neural network algorithm trained with thousands of cardiac images. This one automatically detects the 4 apical chamber and the endocardial borders, and then detects end diastolic and end systolic times from the mitral valve motion, so no need for AKG, and then automatically estimates left ventricular volumes and left ventricular ejection fraction, and also gives us user feedback regarding image quality using the color coding. So this is the color coding. If we have green, he easily recognizes the endocardial borders. The yellow one, more or less, some segments he has some difficulty in recognizing, and in the red one, he has a lot of trouble recognizing it and doesn't give any measures from it. We can see here on this video, he nicely follows the move of the endocardial borders in real time, and also in bad systolic function, left ventricle can do that. So we also compared, once again, experts and novices regarding these automatic measurements, and actually the reproducibility of left ventricular ejection fraction measurements was better for novices with the machine learning algorithm than for the manual measurements done by the experts. So be careful with the human experts. So where are we heading? I think this device has been shown several times. This is a wearable cardiac ultrasound imager that we just attach to the skin in the chest of the patient, and actually can give us pretty good images. And then he works through those images to get some indices like left ventricular volume, stroke volume, cardiac output, and left and ejection fraction. So my take-home messages are ultrasound artificial intelligence-driven tools are here to stay. Real-time VTI and ejection fraction automated measures are very easy to obtain, reproducible, and beginners-friendly and trustable. And the answer to the could artificial intelligence be the new teammate for ER and ICU shifts? Definitely yes. And I think we have to stop this human versus machine thing and be more human and the machine thing. And I don't know if you notice in the opening ceremony, somebody noticed our paper also. Thank you very much for your attention.
Thank you a lot, Felipe. That was very, very interesting. The first two was a very interesting presentation. And now we have Dave Dongelmans, which he will talk about active indications in the ICU and extended possibilities with technology. And at the end, all the questions that you have, so we have more time to talk between the speakers and all the audience.
Thank you for the introduction, and also thank you for having me. Thank you all for being here. I want to do a step back. I am Dave Dongelmans. I'm from Amsterdam. I'm an intensivist, and also I'm the chair of the Dutch National ICU Registry. And I want to do a bit of a step back and look at what are we doing with data, because every session, it's all data, data, data. And it's, of course, it fits these times, but we should also carefully be aware of what can we do with it and where are we going, and does it really help our patients, I think. Well, what does a national registry do? Stuff like this. So the upper panels, you see what we did with COVID. We just measured how many patients there were, relate that to governmental organizations so they could predict what was going to happen in how many numbers of patients there would come, would there be an overflow, etc., etc. We give feedback to our units to say, okay, this is your performance. We give feedback to units connected to each other, and we try to be connected to international networks. The lower panel talks about actionable indicators, and that's actually, we're going to talk about it later. Being the chief of a registry and having audit and feedback as one of my main goals, I thought, okay, how does this work? And we started in 2017 again to look at what is audit and feedback exactly? What do you do and what do you expect? So this is adapted for control therapy. It's a control theory, I should say. And we all recognize this. We all do this all the time. We have an intention to improve something. We change our behavior. We hope that it affects quality of care. We collect data, and we see that the quality of care, hopefully, indeed changes, etc., etc., etc. In practice, of course, it looks much simpler. It looks like this. I think we all recognize pictures like this. We're just in the ward, seeing our patient, looking at the ventilator, thinking, oh, well, we change this, wait a little bit, and see what happens. So this is classic feedback. And of course, we come a long way from this classic feedback, and we're now able to automate feedback. This is really interesting. So what you see here is a closed-loop ventilation system controlling CO2, controlling PO2, and following guidelines. You can give in targets, and in fact, there's no human interaction anymore. So for some appliances, this can be done, but there's a lot of stuff out there where we cannot use a machine like a ventilator to use feedback and enhance the quality of care. And then we come to another question: do we, as clinicians, really need feedback? And the short answer is yes. There are a lot of males in the room. We all think we're the best drivers ever. But if we test ourselves, not so much. And it's the same with clinicians. If you give them back their data, they suddenly realize, oh, I'm not so good at keeping the tidal volumes low, or whatever they were planning to do. This is what you see in this panel here, and you see that green is good, red is not so good, and orange is okay. And you see that for a lot of indicators, unfortunately, people think that they perform really well, but they don't. So we have to help them. And if we help them and we confront them with how their performance is, will they start doing the right thing? Short answer, no. Because, of course, and you can imagine, you think something is really important and you're doing very well, and you still keep at it. You say, I want to be better, even better than I was. So people who perform here in the green, you would think that on the right-hand side, sorry, on the left-hand side, you see what they did before, and then to the right, how they changed their practice. And then the third group is the change overall. People do still work on where they are good at. And they not all think, oh, I'm not so good at keeping the tidal volume, I will work on my tidal volumes, which is, in a way, it doesn't make sense at all. So what can we do with data, and in my case, data from a registry, to try and get clinicians to work on those indicators that are important and that they are not performing well on. Practice variation, showing just practice variation like we do here, and it's a slide in Dutch, but it's easily understandable, I think. Is it a funnel plot about performance, SMR, medical patients and emergency surgery patients in all units of the Netherlands. And you see my unit in a little bit, what is it? Purple or light or whatever color. So I could decide that in medical patients I might try to improve my practice a bit. And if I look over time what is happening in the Netherlands, then I see, for instance, length of stay is slowly diminishing, of course up until 20, because then of course we had some patients who stayed a little bit longer. But then I can say, oh well, using a quality registry, giving data back on length of stay, on SMR, it works. Here you see I can prove it. Well, perhaps. If we look at internationally, we look at what, here we compare the Netherlands with Belgium. The train trip was only 1.5 hours. The differences between ICU in the Netherlands and Belgium is actually bigger than the difference between the Netherlands and Australia. Interesting to see what can you do with it. Can clinicians do something with this these data? That's, I think, one of the things we could try and achieve to learn from each other. What we think now that for registries, national registries, the way to go, and maybe we hope in the end also international, is to use actionable indicators. And what's an actionable indicator? You can imagine that if I tell you your tidal volumes are too high, then it's relatively easy to think what you should do. Maybe train your nurses or whatever. If I say your pain management is not good, your patients are all having more pain than others, you probably know what to do. So the idea is not to give you back the SMR. We say SMR, yeah, okay, what should I do? But we all know that small tidal volumes are better than large. So try to improve that. So the actionable indicator is the indicator where you know what to do. And we indeed found that people, and I have to tell you that those actionable indicators were not just made up behind the desk, but they were, of course, developed in a group of people, users. We all agree upon these indicators. And we see that there is some improvement if people start to use these systems. It even works better if you give them a toolbox. And the toolbox is also, it's evidence-based. Things like, do you have a protocol? Don't laugh, there were instances where there was not a protocol. Or, yes, I have a protocol, but it's also described what are you going to do, for instance, with tidal volume. If you use actionable indicators with a toolbox, you see that people start to improve their practice. So now we're in a situation where, for instance, for pain management, it would be really difficult to ask a machine to do stuff for us. And now we see that audit and feedback using clinicians, using actionable indicators with toolboxes works. Problem here is, though, lag time. Yesterday's newspaper is old news. Yesterday's performance is old news. Last year's performance, what can you do with it? And this is where we get back to the data discussion. How could we take care of receiving data in time so that we could provide feedback to clinicians in time and make make the time until improving their practice as short as possible, but also that you understand what happened, why you produce what you're producing. So if you know today that your tidal volumes yesterday were too large, it's much easier to talk to a team than if you know it was last year. I don't want to talk about fair, but I do want to say that we do need to make all our data fair. If you're not aware of this term, I would urge you to look it up and take it with you, because this is one of the ways to be able to share our data in an easy way, to not only on boards but also international. And the other thing is try to use systems where you can share data really easy, and one of the things you could use is so-called FHIR connections. So I hope I showed you that audit and feedback is necessary. Not always we can use machines. If we can use machines, and I think it was perfectly shown by the speakers before me, then it's absolutely wise to do so, but there are also systems to use us, clinicians, and make care better than it already is. Thank you.
Dave. Thank you so much, Dave. I would like to read something before I make a small conclusion, then we have time for questions. While these technologies offer tremendous potential, it's important to recognize that they should not replace humans, but rather complement their skills and expertise. By embracing these technologies and using them to augmenting our skills and expertise, we can provide better, safer care of our patients and meet the increasing demands of acute care. I read this because this is what we were saying, that yes, machines, data, by humans are fundamental. This answer was given to me by ChatGPT yesterday. You know, I put everything, so what I think and what I believe, excellent about this, we still have, you know, time to learn a lot, but we cannot replace humans. That's what I think. Are there any questions from the, any questions? Otherwise, no? Okay. So, but I was listening to Felipe, his speech, and you know, what I worry about sometimes is all this artificial intelligence, all about, you know, the networking, that you were talking about neural networking. How can we be precise on these measures, on echocardiography, for example? They're reliable, that's what we're saying.
Yeah, well, the validation studies are not not a lot of clinical validation studies, and we did one of the first ones. And now there are several publications about this. And of course, these automatic measurements are very reliable. And then we either trust them or don't trust them. But, and this color coding of this software is especially useful for this, because if you have a green code, you can trust that measure, and if you look at the image, you see that it's correctly positioned, so you can trust that measure because you will do it on that way. If it's otherwise yellow, you think, okay, this may be biased, so you have to know the limitations and you have to know your software. So if it's yellow, okay, I will trust this measure, but I know it can be a little bit biased by some percentage of error. So you just have to know what you're using and what are the limitations, so you can integrate in the clinical decision setting.
Okay. Any questions for Felipe? No?
Yes, please.
Yes, I've got a question for Dr. Michard. On the continuous monitoring on the wards, did you find that nurses spend less time with patients because they don't have to go and check the OBS every 4 hours? And is there kind of any detriment effect of that, or your loss of the end of bedogram, the kind of general view of the patient?
It's a very good question, but I don't have the answer. I mean, I just have in mind studies already done on the topic. But you're right. I mean, that's something we need to keep in mind. I mean, we could imagine they just don't visit the patient anymore. I don't think it's going to happen, but that's something we need to measure in future studies. And I'd like to add, I think if they spend less time in the room during the night, that's probably good news. During the day, sleep disorders, it's a big topic as well. And so being disturbed at 2 a.m. in the morning just to measure blood pressure, I mean, it's crazy. I mean, if we can today measure blood pressure continuously, automatically, without waking up the patient. But during the day, you're right. I mean, that could be, in theory, a concern we definitely need to assess in the future.
Okay. Michard, I was wondering, before we were also talking yesterday, about how the Bluetooth technology today is secure on continuous monitoring. Usually, how do you think about that?
So as I try to explain, I mean, there are different systems today on the market, and some are still using the classic Bluetooth connectivity protocols, and we all experience some disruptions when we are using headphones, or it's just unpleasant, but there is no safety issue. If we rely on monitoring systems in the future to be sure that when patients deteriorate, we are informed 100% of the time, we have to ensure the connectivity protocol we are using is transmitting 100% of the time, that the system is reliable all the time. Otherwise, nurses will never trust the system. So it's also a matter of trust between the technology and the clinicians. And so that's why we need very robust connectivity protocols, and the good news is that industry worked on that, understood that at a very early stage, and there are today medical-grade connectivity protocols enabling reliable monitoring 100% of the time. That's very important.
Yes, I agree in that, because today it's a big issue also, which is also a big issue about data that we get from the ward and everything, and how we're going to use it, and how can that help us also in the future algorithms that can make us decisions on how to help us and also make decisions for patients. So before we were talking about all the big data that we're collecting, and we still don't know how to use it maybe, and we don't have all the algorithms to do it. What do you think about that? Before you were talking about it, and maybe you can explain a little bit better.
I think there's great promise in big data, and there's great promise in all machine learning. But we also see that it's really difficult to get them to the bedside, and that has of course some very logic issues there. There are issues of having not enough data to build something or to validate it. Some groups, they build beautiful stuff, but they never validate it. You think, yeah, well, how can we use it if you don't validate it? Then there's the question of validation, using it somewhere else. can I use a system that is built in Portugal? I don't know, but can I use it safely in the Netherlands? Are the hearts of my patients the same? Well, I presume, but just to make a point, if things change over time, how are you going to take care of that? If care is changing, so for instance, we use different inotropes, does it influence what we see? Is maybe there's something, but I don't know, but all those kind of things hinder clinical or bedside use for some systems. And I think I'm totally wrong of using the example of Felipe. But I think that there's a great promise, but we need to focus on getting those systems to the bedside. And the reason to get them to the bedside, from my point of view, is that we need to
how can we prevent deterioration of human skills in observing patients, doing the right decisions, and my anesthetic nurses are spending much more time looking at the screens and typing in all the bloody stuff instead of looking at the patient. And when it comes to routine surgeries, it's not a big problem really. It takes extra time, okay, it's not my money. But the problem is the computer, but they don't, because they've been learned already to do this first, and this is secondary. Some of them don't, the older ones still on.
Of course, and Michard maybe can go ahead.
Yeah, I agree with you that it's already a concern. I mean, depending, of course, of what you are expecting from new technologies. I think there are already many publications showing that radiologists, for example, when they use now AI systems for the automatic reading of images, particularly the young generation, when the system is off, or even when the system is on, but they look differently at images. They don't look at images as we do, or and now we are ready to welcome the machines, and I think it's not going to influence too much our practice. But I share your concern with the young generation. I saw that with so of course we need to find a way to ensure that medical students, residents continue to learn, I would say the classic way. Important topic, and we need to do research on that, and we need to be very careful about that, and I clearly share your concern.
Can I add something there?
Yeah.
Because I presume you have a car. Perhaps we shouldn't anymore, but I presume you have something else, some chariot with a horse or something. You don't understand what your car is doing, especially modern cars. We don't know what they're doing, but we trust them. And I think this also has to do with trust. We have to start to trust those systems, of course, giving all kind of you understand them, but we should, and if we don't do that, because you said we still have to train people the classic. Let's take some use it. I mean, so why should we train people classic? I think we should I think we should stop.
To me, one of the best examples is, to insert TVCs. I'm an old guy now, so I know how to do it, classic landmark stuff. And I've already met a few young docs who are, without. For everything, of course, but for many things at the bedside, we need to be able to understand what the machine is providing. You mentioned echocardiography. Is it really a good image? Because, we can find examples where obviously the algorithm is looking at or computing information which is obviously not reliable. So I think it has to be a combination, and we should not let the machine do everything. But I share your opinion when you say, of course, we don't need to understand everything. For example, I don't know how the echo machine works, but I still trust the quality of images. But it's really a partnership. Miss anything on images, we probably don't need to learn everything we learned in.
All right, we have a question in the back.
Yeah, thank you very much. Well, I guess it's somehow in line with the previous discussions, but 2 days ago we had a middle income, high incomes countries, and showing very large difference, as we can expect, right, across these countries. So my questions for all you, as the speakers, is where do we believe that AI, machine learning, very sophisticated support for the clinicians, right, should be applied best? In the place where the ICU resource is very low, right? So meaning as well that there might be a lack of expertise, or should that be for the happy few in the world having high income? Or is it for the opposite?
It's a difficult question, I think, but I think it also depends on the technology. What I find in low, middle income countries is that sometimes you are amazed about the knowledgeable. There are doctors who don't know what they're doing. I don't know if you said that, but okay. So that's just a starter. Then the other thing is that there are loads of places where people really know where they want to go. For instance, closed loop ventilation, stuff like that. So I think it's not what we should refrain of is us saying to, and I now say them, you should use this or that in your situation, but we should hands. So, for instance, the problem that people are not seen enough by nurses. Maybe there are not enough nurses. We are not going to answer it for the people who need or could use our technologies.
AI software, they are, I think, mainly useful actually for low and middle income countries. And I know companies, including GE, developing these tools, I think, focus on these emerging countries, because that's clearly where these tools can really change almost everything. Because today in these countries, most people don't have any echo machine, but also don't have the skills to look at the heart, to look at the abdomen, and so on and so forth. But I think what's key is also the way companies are going to price, or what will be the cost of this technology. So again, with my example of pocket echo devices, the good news is that they are not only small, they are wireless, they fit in your pocket, they have AI on board, they are less expensive, much less expensive than big echo machines. So clearly, low and middle income countries are already embracing these new tools. But of course, it might be different if we have in mind a very sophisticated software for echocardiography on a very high-end machine for the cardiology department of the Cleveland Clinic. But I see many applications in low and emerging countries, and maybe actually even more in these countries than in high-income countries. But of course, it will depend a lot how much these technologies cost. Are they accessible or not to low and middle income countries? So hopefully it's going to be the case.
Thank you. Any other questions? There in the back.
Hi, I'm Tiffany. I'm a nurse in the U.S., and I am excited about this technology, but wanted to provide a perspective and have some questions. A lot of times technology is rolled out, and it appears that they don't actually get a bedside nurse to help with the technology, and it actually makes our job harder. So I'm just curious, with these devices, were nurses used in the development of them, and then were they surveyed before and after if it actually was helpful for their job or impaired it?
So when you say technologies, you are referring to what I described, wearables for the wards. Yes, there are surveys published already showing that nurses are actually, most, of course not all, but are actually very happy or pretty happy with these new technologies. They have the feeling that it's helping them, and they can trust the machine. Of course, there are always issues, particularly related to connectivity, and so can we really trust the measurements? It's kind of new, but in surveys already published, I have in mind, the feedback is very positive. Once they understood that it's not going to mean bringing monitoring devices we are using today in the OR and the ICU to the wards. That's not at all the idea. Mm-hmm. The idea is to have completely different monitoring systems which are not going to beep all the time. And so when they realize this is the case, surveys, once again, published so far, are pretty positive.
Thank you. I just didn't see that.
I can share with you some references. It's also, just one more comment for patients as well. In some surveys, they also question the patients. What's your feeling? And one of the main feedback is, I feel safe, I feel safer. Because of course, I know I'm in the hospital, but I don't know where is the nurse. I know the nurse is busy with another very acute patient. I'm not sure when she will come back or he will come back. And so I know now I have electronic stuff that are continuously measuring my vitals. So there is clearly a feeling of safety reported by patients.
Okay. We're just on time, perfectly. Any other, one last question? Okay. So I think we could end right now here. Thank you very much for everyone that participated, and hope you had a nice time. And thank you very much to all the speakers and GE Healthcare. Thank you.
Thank you.